Yeah. Please let me know what's happening.
It's an honor for us to announce for the beginning of one of the presentations of the Egyptian Indian online orthopedic course. Tonight we have a special guest. Our dear professor, Professor Hani Elmowafi, the president of the Egyptian Orthopedic Association and the president of the Egyptian Foot and Ankle Society, and from the Indian side, Professor Sandarajan Silvampatti from India will speak about foot and ankle arthroscopy, and Professor Hani Elmowafi will speak about Charcot Neuropathy, when and what to do. Professor Hani, please, can we start?
Yeah, I'm sure.
Yes,
okay.
Sir. It's sure,
okay.
Sir.
Okay. First of all, I would like to thank Professor Asha for giving me a chance to be chair in this distinguished meeting all over the weeks and all over in every Friday. So thank you very much for inviting me to speaking about foot and ankle, and especially my Charcot neuropathy, when and what to do. My objective for this talk about the goal, definition, and Charcot, and what to do for the cases. Firstly, our goal before we have we treated for plantigrade and stable fixation for the patients of Charcot. But nowadays we are to change this concept, because we need also, we added to the plantigrade and also stability. Another aspect is the correcting or improving foot and ankle mechanics, which is very important for us and for our goals. So, but we have to know that diabetic foot, it is not usually, it is a progressive, devastating, aggressive disease which affected bone and joint integrity. So it may leading to subluxation or dislocation for the joints, and also leading to pathological fracture in the patient with peripheral neuropathy. Of course, this is all of them. Of this will leading to a debilitating deformity, which is very aggressive ulceration due to deformity and leading to mechanical ulcer or something like that. And we going to the osteomyelitis, at the end it leading to amputation. But actually, before we speaking about when to do operation, we have to know, which is very important items, is the neuropathy and poorly controlled diabetes increase the surgical side of infection. It's the foot and ankle surgery. So, as we, according to this research, we have, if we look into the diagram, we found that if the patient is non-diabetic but has a neuropathy, just only neuropathy, it may be the risk of infection increases up to 7%. If it is uncomplicated diabetes, so it may be the risk is about 3% to the infection. But if the complicated diabetes, which means neuropathic foot and also uncontrolled diabetes, so the risk of infection would be increased to above 10% or may leading touch to the 11%. And also we have a many classification, but the recent classification is introduced by Rogers in 2008, and he beginning is to know that what is the risk of amputation, or as a prognostic value for to know that if it is high risk of amputation or low risk of amputation. But actually, if we look into this classification, he beginning with acute Charcot without deformity. Acute Charcot without deformity, I think it is, we have an orthopedic surgeon, we haven't any rule in acute Charcot without deformity. But actually, we have to making some idea about the classification. Only all classification must be a descriptive, but actually none of this classification is specified to the management or also the outcome or with the relationship of classification stages. So the ideal classification system, it must provide an important clinical information to assist the patient to establishing the appropriate treatment option and also setting a reasonable goals in the treatment. So first, we have to know that what is the time of surgery or what is the perfect time for surgery. According to Armstrong, which is also a clinical classification, which introduces in 1998, introduces a very simple classification, consists of acute and chronic. And in acute stage, there is the foot become hotness, redness, and also it is inflamed. So he suggested that the best treatment for this in acute stage is a conservative treatment, which is the treatment choice. While in chronic stage, after the inflammatory is disappears and also resolution of everything, even the bones become new bone formation would be okay. If there is any residual deformity or any ulcers or something, you can interfere with this. So, but why conservative treatment is conservative treatment in acute stage is the treatment of choice? If we are looking, there are many theories about the acute Charcot, but there is a consensus about the most acceptable theory is the neurotraumatic and neurovascular, which consists of 3 neuropathic affections: is autonomic neuropathy, motor neuropathy, and also sensory neuropathy. In anatomic neuropathy, there is affection in the blood flow, so it increasing the blood flow, and also leading to as regard to increasing the blood flow, the bone become osteopenic. So it may leading to dislocation or fracture, whatever. And also the motor neuropathy may be making what's called muscle imbalance. Muscle imbalance making more stresses in the tendons and joint and the ligament. So it may lead to subluxation or dislocation, and of course leading to deformity. And of course, the third neuropathic affection is a sensory, which sensory here, it is insensible foot in the over the dislocation, whatever, fracture or whatever, leading to more deformities, leading to ulcers, and also may leading to osteomyelitis and amputation. And this is a visual circle. So by further increasing blood flow, so of course leading to fracture, dislocation, and osteoporosis. And this is why conservative treatment is important, because any interference at this stage, it leading to a big problems to the patients, and also of course it may leading to implant failure. Actually, it may leading to amputation, or if there is an infection due to implant failure. In our institute, we have what's called a diabetic foot team, which it is this team is multidisciplinary team. It consists of of course, the podiatrist and also vascular and plastic surgeons and orthopedic. There are some ancillary surface like radiological, like nuclear medicine, also podiatrist, and also test. So if we said that when and what, when conservative treatment, of course, it's an acute stage, as we see that inflammation, hotness, redness, and so we have to make an conservative treatment. And actually, in our team, the podiatrist or physical medicine in diabetes making and treated these cases by offloading cost and also non-repairing until the chronic stage is resolved. How we know that the acute stage is resolved? This is we see the difference temperature between the affected food and the healthy food. And if the temperature is the same, so we have to say that acute is disappeared. And if there is needed the patient or there is a residual deformity or ulcer or something, we can orthopedic can interfere. But if it is mechanically accepted and to blunt grade without any pressure affection on the skin, so we said that okay, it's conservative, and the patient usually continues this. So conservative treatment mandatory in acute stage. And also there is an example for the chronic stage. There is two cases here. This patient has bilateral Charcot. Of course, it is a chronic Charcot, but the left side, it is usually there is an deformities. While the right side, there is an plantigrade. Both are stable. The right side is stable, and also the left side is stable. But the problems in the left side, there is a deformity as the foot is inverse. And of course, we see that here there is an, as we see that there is a pressure affection in the lateral mirrors. So the skin over the lateral mirrors is usually serrated. It may end to ulcer, or so we can say that it is a mechanical ulcer because there is a pressure ulcer there. So we have to interfere operatively in the left side, while right side must be treated conservatively, and the patient always follow up. And if we see the case after 7 years follow-up, we see that the right side, which is stable, is the same. X-ray is not looks, it is good, is the same. There is no deformities. There are also it is accepted mechanically, and just there is an ulcer in the big toe, and of course the vascular surgeon, the patient is transferred to the vascular surgeon. But actually, here the left side, it is stable. As the patient, we see that lateral side, the lateral and also the anteroposterior view. It is a good alignment. It is mechanically accepted. As regards the patient is followed for 7 years, it means mechanically accepted, and the patient can walk there. Another also example for another region in the square, in the we said that it is an not prenavicular, it is pre-metatarsal. Pre-metatarsal is affected the metatarsal and also the forefoot, and we see that it is a less frank injury, and the patient is beginning to bone formation, and also there is no deformity as we see here, and the skin is little bit there is no any pressure in the on the skin from the deformities or something like that. So we decided that the patient the best solution for this patient is a conservative treatment. And if we see the patient after 3 years follow-up, we see that the good quality of bone first. The second, it is mechanical. It is accepted for the patient, and the patient is now, it is walking not of course normally, but also it is the patient is wear an diabetic shoes, but moved freely. Who can move and walking and everything without any problems for this patient. So stable means I'm going to make a conservative treatment. But if we look into another one, it is what is called, we always classify this cases as what is called the prenavicular complex. Prenavicular complex, it means affection of midfoot and mid-tarsal foot. And if we see that the mid-cuneiform, it is dislocated from the side, and also we can hear and pressure on the skin, leading to the skin is serrated. It may be changed to the ulcer, and so this patient need operative, not conservative, to make a good alignment for the patient, and also to get a mechanically accepted foot. In another cases also, we say that we say a pre-talar complex. Pre-talar complex here, the patient affected in the hind foot or the talus and the navicular and the cuboid, but actually there is here the skin, there is an ulcer, but the ulcer is infected or not, and what is the cause of ulcer? After we made an plain X-ray or in standing position, we found that here, this is this picture like that. It means that this is not stable. This is an pseudoarthrosis, and the patient, when standing, it is making the pressure in this area and resulted in ulcer, of course. And here the patient is, as we see this patient, it is as an ulcer. So operative treatment in these cases is very important. And also every investigation and standing position and everything to see the patient very well. Of course, all of this example, it is unstable. As we see here, it is like a puzzle. The metatarsal, it is completely dislocated. And here, this is a prenavicular and also affected the skin and this patient in the standing at the thing. So unstable, if there is instability, it means an operative focus. And of course, all these cases, it is unstable. So we have to do an operative to improving the mechanical foot, the mechanics of the foot, at least accepted mechanically. So when we said that, we observed over years of outcome of our cases in treatment of Charcot arthropathy. There is a different basis regarding to that. Anatomic region affected, how many anatomic region affected, if there is one region or more than one region. Also, the patient, after becoming at the chronic stage or resolution of the acute stage, if there is any deformity, will be residual deformity there. And also, if there is a patient is the foot is stable or unstable. And of course, the most important things is you have to look into these cases is the presence of ulcer or not. And all of them we introduced in the 2021 and what is called Mansoura classification or Charcot arthropathy. It depends on, firstly, it is two types, type 1 and type 2. This type is defined as a amount of region affected. For example, if we say type 1, it means the region only, the ankle region will be affected, or the hind foot only affected, or the mid-tarsal only, the like less frank or affection, or forefoot affection. So this means single region. But the another type is type 2. Type 2, it is usually more than one region. For example, I think we saw that there is sometimes hind foot and mid foot also affected. So this is type 2, or mid tarsal with tarsal and forefoot affection. This we said that type 2. So what we do? If we see these cases, this is a type C. Type C means one region, which here it is an ankle, the ankle side only, an ankle region, as we see. But it is stable or unstable. It is unstable. This is the first. But maybe if there is deformity or non-deformity, but actually here there is a little bit to the valgus deformity, but deformity in this instability, it is not an important rule. The rule is the instability. So the patient must be undergoing to the fixation, or to get a plantigrade and rigid fixation. So we have a little bit technique by hybrid fixation, is a retrograde nailing with and laser frame, and we fix, as we see that we fix the proximal part by interlocking screw, while the distal screw, distal interlocking, we didn't put this screw for allowing the roof to making and compression during the follow-up of all these cases. And the patient here, the follow-up after about 1 year follow-up, it is a very good alignment and stability, which is a good. Another example for the patient here, this is we said that type 1D. 1D because it means there is an ulcer, whatever stable or unstable, and also is deformity, but with mechanical ulcer. So the ulcer is another category. So what we do the same as this is in one region. We just fix the region, and also we make what's called the hybrid fixation. And we have this technique are published in 2018 in Foot and Ankle International as a hybrid fixation for Elizarov with continuous compression, which is this compression leading to enhance the union. And if we see that the patient here with Elizarov and the ulcer here with beginning to heal, and this is a patient after the removal and beginning to walk, and the patient standing, the ulcer is completely healed, and there is no problem for that. But actually, we open and we removed it. So it is very important to treat it as in one region, as this is, and you have to fix very well the region affected. Another example for also type 1, it is this patient had an amputation to the big toe, and also if we see that there is a dislocation of the second tarsophalangeal joint, in the second tarsophalangeal joint, and this is make a deformity for the toes. And this patient, if we would like to analyze the mechanics of this foot, we have two problems. First, increase the angle between the first metatarsal angle. The first metatarsal angle, it is a little bit more than 20 degrees, and also the deformity of the second due to a dislocation. we just correct the angle between the first metatarsal and the second metatarsal, and also we did what is called excisional arthroplasty to align the second tooth and also shorten the second tooth. So we get a good benefit from this. So it is whatever is stable or unstable, but there is an deformity and also there is a mechanical ulcer. So we consider it as a type 1D because it is in only 4 foot in one region. And this is a patient during the management. This is during the beginning before the operation, and the beginning. This is 3 weeks from the operation here. The ulcer began to heal, automatically heal, but just normal dressing and just, or traditional dressing with saline and alcohol and betadine, and this is follow up here. And this is a patient after 1.5 years from the correction of the first metatarsal. And here this is the patient follow up after 5 years. If we see that the patient is going well, it is actually going well, and also the skin, there is no need. The patient, I think, it didn't need an graft, just correct the mechanics of the foot. So everything is going well. And also, if we look to the skin, it looks like a normal skin. So just to correct mechanics of the foot, you get a normal skin with ulcer. So get a good chance for the ulcer to heal and the skin to heal. And this is the same patient after 9 years. The patient is working very well. She is a housewife, and so she is. I think it is going very well. She is happy, satisfied with the results, and can do everything without any problems with her. So we're going to another types. The type 2. Type 2, we said that it's more than one region, and we said that if it is unstable with or without deformity, it is not important, but it is unstable. So we have to going to fix. We did what is called a triple attack. A triple attack, it is we make an also retrograde nailing. The first, the second, we connect the anterior or the anterior border of the shin of the tibia, or of the middle of the tibia, medial surface of the tibia. When we with the navicular, we make a decortication of and remove the articular surface of the cortex of the tibia, and also remove the articular surface and making an just cortical bone to or raw surface to get healing this. And the patient here, and also the follow-up of the same technique, we make an proximal looking, but we didn't make a distal looking to allow the lesser roof, especially posterior, to make an compression posterior, because here the lesser roof is completely affected, or the affection of lesser roof actually it is in the posterior part on the hind foot more, not in front of the midfoot, because this is the breadth as we see. And this is a patient after complete healing, and she looks very well, and the patient is satisfied with the results. And we removed the apparatus, and the patient under or wear the walker for about 6 months with walker, and after that now she wear a diabetic shoes, just diabetic shoes to protect her foot. And this is a patient follow up here after 6 months from the operation, and this patient called me and she has problems. She has some irritation. The we see this is looseness in the screw, and this screw make an irritation to her during wear the shoes, and also sometimes make some irritation in front. But actually, this is when I say this patient and how the union is good, the quality of union is very good, and the patient is stable foot, and also mechanically it's very important. And mechanically it's very good. Another example for these cases, it is unstable, but it is we consider it as one type 2 according to Mansoura classification is type 2C. So it is unstable, whatever is deformities or not, or whatever. But actually, the patient undergoing to reconstruction of the foot, and also as I said that to improving the mechanics of the foot. And this a patient here, we did an what's called triple attack. We make an retrograde nailing, we make a plate, but this plate we found that we have to, which is better to do in lateral aspect, not in the medial aspect. Actually, I put the plate in the anteromedial, but in this cases, especially these cases, we found that it is better to get more, because I think the amount of bone it is not enough, and I tried to, what I do. So I put in lateral, in the lateral side, as we see here, just in the lateral side. And after that, we removed the plate, but we removed first the apparatus. But during we removed this apparatus, there is an dehiscence for the skin, and the plate is become compressed skin. So we remove it, and the patient, after 6 months follow-up, Elizarov, and this the patient here, he can walk and everything is okay. And patient, I think follow-up, the last follow-up, I'm sorry I couldn't present the last follow-up, but actually he's working very well, and he's satisfied from his results. This is an also example for unstable and ulcer. So we said that type 2D. And the patient underwent to the fixation of lateral and medial column to get stability. And the patient here, just after 10 days from operation, the ulcer is beginning to improve, because we change the mechanics of the foot, and here after 18 months. And if we look to the foot, there is no deformity mechanically, there is no arch, but actually it is aligned without any pressure on the skin and the patient here. But actually, after 5 years, the patient came with failure of the fixation of the implant, and also she got an ulcer. So this patient underwent to fixation, but more rigid fixation with plating and also screws, and to get more stability. And here, if we said that there is no any deformity, and also there is no any compression in the skin, and the patient here follow up, but without ulcer, the ulcer is healed and the patient is going well. But actually, I don't know what happened in the future. Of course, me becoming again, I don't know. But actually, no news, good news, so it is good for me. And another example for cases here, this a patient is triple, but it is 2D. But if we see that, if we see this patient, we did a triple attack, but she has an amputation for the big toe, and also the patient with ulcer, especially in the medial aspect here. And the patient, this is after 3 months from removal and or 6 months after operation, it looks good. I think it looks to in beginning. But this patient is always suffered the last 3 months from the follow-up. She always suffered and said to me she has a pain. I said that you are looking good and everything is good. But actually, I don't know what happened actually. But okay, she suffered from pain, and I thought that it is a psychic element for this patient. But after 6 months from removal of the apparatus, I found this. Firstly, there is an here protrusion of the nail and also acute recurrent extirpation of the acute with destruction of this. And this end for amputation. So you couldn't expect, especially in type 2, more than one joint, and also with ulcer, you couldn't expect what happened. And also the complication, it's more and more. For example, this patient is here, but after 10 years from the patient came to me after 10 years. He suffered from ulcer due to protrusion of nail. The nail became protruded after that. We removed the nail and the patient is doing well. I hope it's going well as long as the patient is the diabetes was controlled for this patient. And this is here. So we can conclude this. Proper timing of surgery with strict follow-up is mandatory to achieve the ultimate goal of obtaining plant-grade, stable, mechanically sound, and also painless. Affection of single region has built a better prognosis than the affection of 2 more regions. And also surgery, we can say that surgery indicated in all cases of type 1C and 1D, and of course type 2B. And 2B, it means with deformity, type C with deformity, but unstable, type D unstable with ulcer. So to get stability and correction of deformity and to prevent more complication. But actually, mechanical ulcer, stage D, carries the worst prognosis and the highest complication rate, especially in type 2D, and might predict the risk of amputation. And finally, thank you for your attention, and I hope to help you or help all audience to make how to decide and the time of surgery. Thank you very much for attention.
Thank you so much, Professor Hani Elmowafi, for this very interesting presentation. Professor Hani is the president of the Egyptian Orthopedic Association and the president of the Egyptian Foot and Ankle Society. Thank you so much, sir. We will start the discussion, and we are ready to receive any questions to Professor Hani. The first question is from me, Professor Hani. I think from your point of view, sir, that the main aim of the treatment is to obtain a stable foot and ankle construct. So, sir, first of all, I would like to welcome Professor Sandarajan. Thank you so much for joining us, sir. Thank you so much.
Thank you, sir.
Thank you, sir. Thank you so much, sir. So when do you decide, Professor Hani, to use internal fixation, external fixation, or combined hybrid internal and external fixation? I think you have to have a stable internal or external fixation to obtain a proper good results.
Actually, it's better to make an proper fixation and also hybrid fixation. I usually using an ankle. Especially the ankle is, I think it is so difficult, and also the results not in all literature. I think the results is not wow or given a good results. But actually, here we make an hybrid fixation. And I think this is an acceptable idea for hybrid, as we make an retrograde nailing, and also we make a conservative or during the follow-up, we saw that if there is any distraction of care, we can make an compression. Because so I said that we make an proximal screw fixation while the distal is without fixation. So it is a dynamic compression. So we saw during the follow-up, we make an always compression at the distal at the ankle joint, and also, and if there is in type 1 for the ankle, it is an easy, and I think we got a good result up to 90%. But actually, in cases of the type 2, it means hind foot with midfoot, also affection, and so we would make an plating anterior, and also retrograde nailing and fixation. So in this time, it is very important. We said that we're making an posterior compression only, because the construct anterior is already compressed with the plating during I introduce or during insert the plate. So we make a compression, we increase the compressions with plate, and also we make a continuous compression with the Elzaroff posterior. So we got a good results about these cases.
Yes, sir. Thank you, sir. What do you think about the concept, sir, as we make with using the Elzaroff, we make a bone transport, we can make a soft tissue transport to increase the vascularity and make proper healing of the ulcers in case of Charcot foot and ankle. What do you think about this concept, sir?
Actually, the colleagues in China, I think, make a good series about or a big series about the transport, is longitudinal transportation, just making an osteotomy in the longitudinal in the tibia, and making a distraction and then compression and returning that. This is actually driven, and also I think making an arteriogram for the cases pre and during transportation, and after or post compression. I think the vascularity is increased very well, and also actually the ulcer, even the ulcer is an ischemic, it will improving, and so I think it is a good idea. And but actually, I haven't no experience about this. Actually, my experience about if there is a mechanical ulcer in whatever in the ankle or the foot, and I can correct the mechanics of the foot or mechanics of the ankle to the little bit normal mechanics, or about to be normal mechanics. We corrected it. And so the patient is just, I think it's healed very well. And the patient, I think, it doesn't need to do a graft or something like that.
Thank you, sir. Dr. Srinivas, please.
Thank you very much, sir, for an excellent talk and for sharing your experiences and insights on this topic. Very often we see that lots of these cases present with advanced stages of the disease, with destruction of the joints in the foot and deformity. Is there any way we can identify early stages of neuropathic joints? Is it possible to identify early before destruction of the joints?
Actually, nowadays we are making a research or protocol of research to make how to detect Charcot before affection of the foot, and also if there is any patient had a fracture, what types of if it is going to becoming Charcot, or becoming vascular or something like that. But up till now, it's so difficult to say that the patient is going to the Charcot. But okay, if the patient is coming to Charcot, the best way of the treatment in acute Charcot is firstly conservative. This is the best way, as Armstrong said, that the conservative. But during this period, the patient, there is of course, increasing blood flow, leading more destruction to the bone and more affection to the bone. So it is better to ask the patient for non-weight bearing. He doesn't, or the patient should be non-weight bearing completely to prevent more destruction to the bone, to prevent more. Actually, this method, I think it's improving the cases without this more destruction or the bone loss is more and more. But actually, I think we faced in Egypt here, as we said, some cases for me, I present, I think there is some more amount of bone is totally lost, and the patient is okay. We do the best, but actually, okay, non-weight bearing nowadays, I think the results is very good to have a good stock of bone. You can, if you need to make an operative interference, you can do with a good stock. But also, if it is, we make an offloading cost, maybe make an instability with the plantigrade and mechanically accept. So the patient, I think, patient doesn't need to make an interference, operative interference. Exactly.
Thank you so much, sir. Professor Sandarajan, please.
Yeah, regarding the same question, it's a very important question by Dr. Srinivas, because being India is the diabetic capital of the world, we do see huge number of Charcot disease. I think the question is to how to prevent this Charcot is the most important questions in our mind. I think the creating the awareness how to diagnose Charcot in the early stage is the key. As he said, if any patients presents with more than 5 years of diabetic patients, if they come with any foot swelling, we always tell them to take an X-ray, because many times what happens when the patient presents with acute Charcot, it may look like a cellulitis. So people think there's a diabetes, they just treat on IV antibiotics or oral antibiotics for a week and they leave it without taking an X-ray. Because by taking an X-ray itself, you can see that there could be an early signs of Charcot. And always it's very important to do a neurological examination. One important neurological examination to see is that position sense. Very simple test to just doing the great toe positional sense will diagnose whether the patient has got a Charcot neuropathy or not. Once you know that it's a Charcot neuropathy by identifying with the positional sense, it is important that protect the foot, as Professor Hani said, it is important that you have to protect the foot. You treat that swelling, treat that acute Charcot with the total contact cast, non-weight bearing for many months. I mean, you had to call the patient, you have to counsel the patient. Every month you have to take out the cast and see whether all the skin is okay. So it is it's a course of like almost 1 year duration. So this patient has to have a proper follow-up, and they should follow the strict protocol of non-weight bearing till the Charcot gets consolidation. So that is a very important aspect of treating the Charcot conservatively. They do very well. If you identify them without deformity, if you protect it, you make them non-weight bearing, they consolidate very well, and these patients can avoid all these surgeries, major surgeries.
Actually, thank you for your comments. I agree totally about your comments. And also nowadays, when in our institute we're beginning to make an project with our colleagues in USA about how the problems for us nowadays how to detect is a patient has a neuropathic or going to vascular enzyme. This is a very important point. And actually, we want to prevent the neuropathic or beginning of the neuropathy, and also the patient, select the patient who going to neuropathic to prevent, and also going to vascular to prevent. And so we are going with, as I said, that we are a multidisciplinary team in diabetologist and also vascular, and also our colleagues in USA. We are going to make a project about how to prevent and how to treat and how to decrease the risk. I think all of these items are going to, I hope, we are reaching to something acceptable. Okay, thank you very much.
Thank you so much, all of you, sir, for this very valuable discussion. Thank you so much, Professor Hani Elmowafi, for this very valuable, interesting presentation. We will move to our next speaker. Our next speaker will be from India, Professor Sandarajan Silvampatti. Professor Sandarajan from India will speak about foot and ankle arthroscopy, and Dr. Srinivas will introduce him. Please, sir.
Thank you very much, sir. I'm sorry we are starting a little late today because of a small technical glitch. I would like to thank Dr. Sandarajan Silvampatti for accepting our invite to attend, to give his talk today. He'll be talking on arthroscopy of the foot and ankle. He is the head of the Department of Arthroscopy and Sports Medicine at Ganga Medical Center, which is a well-known trauma and scopy center in Coimbatore in Tamil Nadu in India. He has worked as a past secretary of the Indian Arthroscopy Society, president of the Tamil Nadu Arthroscopy Society, past president of the Indian Association of Sports Medicine and Indian Foot and Ankle Society. He's also an ISACOS committee member of Foot and Ankle. He's an associate editor of Journal of Clinical Orthopedics and Trauma, and served in the editorial board of journals, and he's also a reviewer of multiple journals. He has about 60 research articles published in international and national index journals, about 10 book chapters, trained more than 80 fellows in arthroscopy with short and long-term attachments. He's presented some 660 presentations in lectures, in national and international conferences. He's been a postgraduate teacher for DNB and FNB, and also as an examiner, and he's guided many postgraduates in the last 15 years, and also served as an examiner for National Board and the Tamil Nadu University in the state of Tamil Nadu. He's also conducted multiple courses, the Indo-US Foot and Ankle course, annual meeting of Indian Association of Sports Medicine, the Ganga Arthroscopy course he conducts regularly, the Indian Foot and Ankle Arthroscopy Conference, ISCSA and Ganga course, and IAS Con 2002 after the COVID in Coimbatore. Thank you very much, Dr. Sandarajan, for accepting to give the talk here. Over to you, sir.
Srinivas, can you see my slides?
Yes, sir.
Okay, thank you, all the office bearers of Egyptian Orthopedic Society and the members of Egyptian Orthopedic Society. And also I thank Dr. Srinivas for having me here in this meeting. And my insight today is going to be on the ankle arthroscopy, and mostly I am going to talk about only ankle arthroscopy and the anterior and posterior ankle arthroscopy. So ankle arthroscopy is not very new. I think all of you know that Michael Berman in 1931 has introduced that, and Chen is the first author to report large clinical series of ankle arthroscopy. Why arthroscopy? I think we know it allows the direct visualization of all intra-articular structures of ankle Without an arthrotomy or a malleolar osteotomy, it is a big boon for many conditions in ankle. It has also decreased morbidity and faster recovery time than any open arthrotomy. But it is very important to understand the anatomy of the foot and ankle, arthroscopic anatomy of the foot and ankle to do an ankle arthroscopy. So you should know that what are all the ankle ligaments in the anterior and posterior, like posterior inferior tibiofibular ligament and the transverse ligament and labrum, which we should not damage when you are doing a posterior ankle arthroscopy. This is another view of the posterior view where you see that intramalleolar ligament, posterior inferior tibiofibular ligament, which you see most often in the posterior malleolar fractures. And these ligaments can be visualized in the posterior arthroscopy and should be protected when you do an ankle arthroscopy. Where all you can do an ankle arthroscopy, you can do the most common indications. I'm just in an order I'm going to go through. It's the most common condition which I do ankle arthroscopy in osteochondral lesions, ankle instability repair, anterior and posterior impingement, synovitis, traumatic or inflammatory, sometimes in a chondromatosis to remove the loose bodies, uterocalcaneal spur excision, ankle fusions, or in case of arthropfibrosis, in the post-traumatic conditions, or very rarely you can do it in even benign tumors. What kind of anesthesia required? Most often we do the general anesthesia. You can use you can do it as an outpatient, or you can keep it in one day. And most often you do on a regional anesthesia. How to position for an ankle arthroscopy? So when you do an anterior ankle arthroscopy, you do it in a supine position. Make sure that you leave it at least 1.5 to 20 centimeter, 10 to 20 centimeter from the operating table, so that you can do the both dorsiflexion and the plantar flexion, which allows more visualization and give you more freedom. And also it gives you more freedom to move around the ankle on this side, medial side or lateral side, or in the distal to the foot, so that you can go on to the all the sides. Or other way of when I do an ankle anterior and posterior scopy, this lateral position allows you by tilting the foot anteriorly like this. At the same time, you can do it you can do the posterior ankle scopy by adjusting and rotating the foot. So this position helps you that without changing the position during surgery. So I will do like this position when I combine both anterior and posterior ankle scopy. Normally, we don't need a pump for this kind of conditions because it's a very small joint. Gravity flow system is more than sufficient. You can use a manual traction, or you can do a mechanical distractor. Mechanical distractor is a bit cumbersome in ankle arthroscopy, in my feeling, but many surgeons uses the mechanical distractor. However, you should be aware of the risk of AVN of the talus and potential for a vascular injury. And you have to be careful that you should not exceed too much weight. And also distraction should not exceed 7 to 8 mm for more than 1.5 hours when you do this kind of mechanical devices. But usually I do with just manual traction with my fellows. And standard arthroscopy is more than enough, like what you do for a knee arthroscopy, like a 4 mm, and 30 degrees arthroscopy is more than sufficient. But when you do one like osteochondral lesions where you want to reach middle of the talus or the tibia, better to have a 2 and 2.7 motorized burrs and shavers, which will help you to go into the joint, especially when the joint is very tight. So you should have a armamentarium of both 4 mm scope as well as 2.7 mm scopes and the instrumentations. The most common portals what we use for ankle arthroscopy is the anteromedial portal and the anterolateral portal. Of course, we can have the option of using the anterocentral portal, posterolateral portal, and posteromedial portal. This is how we make an ankle arthroscopy. This is supine position, that is the medial malleolus, that is the anteromedial portal, that is the tibialis anterior. You could just go medial to that. That is the extensor tendons, and you can see that extensor digitorum, that is the lateral to that. You have the anterolateral portal. You should have a superficial peroneal nerve, which I am marked here. Most often it can be easily visualized by through your light source from the medial side. You make just a stab incision. You don't go all the way inside because you can have a saphenous vein inside. So you have to be very careful. You have to just use a mosquito forceps to open up the joint. Unlike a knee joint where you go around 45 to 90 degrees angulation, here you always go flat and parallel to the ankle joint here. And this is how we insert the trucker. Or you can insert 10 to 20 ml of saline inside, distance the joint, then you can insert the trocar. Then you can see the visualization of the light, you can identify the superficial peroneal nerve, avoid the injury to that, and make a needle for the anterolateral portal. So this is how you visualize the joint from the medial side. That is the joint and syndesmosis of the on the lateral side. That is the fibula. That is the tibia, and this is the talus. Then you can visualize the joint on the lateral side. You can see that is the tip of the fibula, and you can come to the medial side. Sorry, that is the lateral side. You can see that that is the anterior inferior tibiofibular ligament. And sometimes when the joint is lax, especially in the ankle, especially when there is an instability of the ankle, you can easily visualize the posterior ligaments. Otherwise, it's very difficult to visualize the posterior. You can see that as intramalleolar ligament, which cannot be seen in the normal ankle joint. That is a case of an instability. So OLT usually happens because of the osteochondral dissecants or osteochondral fractures or osteochondral defects. The 50% are secondary to the ankle injury. Unlike the knee joint, ankle OCDs are more commonly due to the ankle injury. And 94% of the lateral lesions are said to be secondary to trauma, and 22% are from the medial lesions. It can be easily diagnosed by X-ray itself, but the CT and MRI gives the more sensitivity and sensitivity in diagnosing this. MRI is the most sensitivity and has got almost 96% compared to the 81% with the CT scan. So anything which you suspect on the X-ray, we should do an MRI scan. It is always important to differential diagnosis like ankle and subtalar arthritis, peroneal tendinopathy, impingement, hindfoot coalitions, and inflammatory arthritis. Because osteochondral lesions can be an incidental finding in many patients. So if you see an X-ray, is there an osteochondral lesions, make sure that clinically correlate whether the patient is having a tenderness over that particular spot. If there is no tenderness, you no need to address. It could be a sometimes incidental finding that can have a differential diagnosis like this. So always the clinical examination and correlation with your MRI is the most important in ankle and foot. This is the case of 38 years old male patient presented with pain in the left ankle and giving way of the ankle on weight bearing. History of ankle twisting injury 2 years before while playing and treated conservatively. No other involvement, and you can see that is the X-ray, and you can see the X-ray very carefully. There's an anteromedial side, there is a small osteolytic lesions over there, and you see that MRI, you can see that there is an osteochondral lesion that is around 1 to 1 centimeter in the anteromedial lesion, and patient has got tenderness exactly over the side. So that is the arthroscopy which you see that, which are visualizing from the anterolateral side, anterolateral portal, and that is the medial malleolus, and you can see that osteochondral fragment which is lying very loosely over there. You just take it using the curette, or you can use the grasper, and you can see that is the osteochondral lesion which is around 1 centimeter or 1.5 centimeter. And in the small lesions, the microfracture is more than enough. Like this, what we do the microfracture, which gives a very good pain relief and long-term results in these cases. When I come to the second, I just go through the examples of each condition which we do an ankle arthroscopy. This is a chronic lateral ankle instability case, which I'm going to talk about. It's usually one of the common source of ankle dysfunction. There could be an ATFL injury alone, or it can be combined with the CFL injuries. Make sure that whenever patient present with the chronic ankle sprain, you get to examine whether the patient has got any cavus foot or a varus heel or a flat foot. Because if you want to address the chronic ankle instability, if there is a deformity, you have to address the deformity as well as the ankle instability. If you do only ankle instability with the deformity, the chance of failure is very high. And also look for a tight gastroc. If it is there, you have to release it. And also the test for integrity of anterior talar fibular ligament. One is the anterior triad test. Another is the talar tilt test. Talar tilt test also gives you a clue that it is not an ATFL alone. It could be a calcaneofibular ligament also. You can manage these cases conservatively by doing a rehabilitation like a peroneal strengthening exercises, tendo-achilles stretching exercises. And if it fails in spite of your conservative treatment, then you can do an arthroscopic or a open repair or reconstruction, or arthroscopic repair or reconstruction. This is a case of 17 years old female patient presented with ankle pain 6 months. It's a twisting injury while playing a basketball. She is a club level basketball player, presented with the persistent ankle pain after the first twisting injury. And you can see this patient has got a more talar tilt, and that anterior dryarthris is little more than the what we got it from the normal side. And you can see that MRI, X-ray is normal. MRI shows the lax ATFL. Sometimes you may not see the complete rupture, but there could be a lax ATFL also. And you can see that intact calcaneofibular ligament. And if you take a stress X-ray, you can see the large opening in the lateral side that indicates that patient has got a lax ATFL. So here I was doing open brostrom. Now I do mostly arthroscopic. This is the all inside arthroscopic repair. I'm seeing through the medial portal. This is the talus. This is the ATFL, which I'm seeing, which I'm showing with the probe. And this is the fibular, lower end of the fibula, with where the footprint attachment of your ATFL. So you prepare the fibular attachment with the scoop, or you can use the burr. And once you do the preparation of your attachment, then you get here I'm using the suture tapes through the lateral portal and make a cinch like this. So that allows to hold that whole tissue in a bunch of in a bunch, so that you can put back to the fibular attachment with the knotless anchors. Here I'm using the cannula for my drill. And what I do that I use the knotless anchors to attach these cinched tied knots from the ATFL to the footprint. I use one is very lowermost here. You can see that there are two holes over there. So I put a 2 push lock anchors here, and you can see that slowly hammer that, then it goes and attaches over there. And you can see that is the after the repair, what you are seeing, that is the push lock, and what you are seeing in the bed is this is the ATFL. You can see that now it is very nicely taut, and so that's how you do the all arthroscopy repair. So arthroscopy repair in patients with a sufficient ligament quality provides good to excellent results. And if you had to do a reconstruction technique, if there is a tissue quality is poor, and you can use an open or arthroscopic procedures on that. Another important scope for your ankle arthroscopy in a retrocalcaneal bursitis, but it's not very common, because most often retrocalcaneal bursitis can be associated with the tendo-Achilles spur. When you have a spur inside the tendon, it is very difficult to do an arthroscopy alone. You may need to do an open procedure. So when there is no spur, with the patient only with the retrocalcaneal bursitis, that means they should have a pain and tenderness on either side of the tendo-Achilles. That means that is a Hanklin's deformity with the retrocalcaneal spur. Retrocalcaneal spur. No, there is no TS spur here. So here in this case, we can do an arthroscopy, and you can exercise the pump by using the foramen burr on the both medial and lateral side, by switching the scope on either side. And this is how you completely remove the whole Hanklin's deformity and prevent the pressure of the tendo-Achilles over the Hanklin's bump that can relieve the pain for that particular patients. Another important diagnosis, important scope for ankle arthroscopy in an anterior ankle impingement. I think Egyptians, you know that you have a lot of footballers. So this could be an etiology, could be a soft tissue or the bone. And usually the patient presents with anterior ankle pain and painful terminal dorsiflexion on physical examination. And the anterolateral impingement usually happens because of the repetitive impact on the forced dorsiflexion, especially in the footballers. It starts with the soft tissue inflammation and cartilage lesions. Later on, it goes for a tear, and sometimes there could be a tear in the anterolateral capsule. Mechanical instability that can lead to, again, synovial hypertrophy and scarring that can cause the anterolateral impingement. In the early stages, patient can have only anterior ankle pain in dorsiflexion or the long period of exercises. But in chronic cases, because of the spur, patient can have a limited ankle motion. And this is the X-ray, shows the typical anterior spur. So you can see the both on the talar side and also the tibial side. The weight-bearing X-rays will give you and show that impingement over the case. And make sure that when you do an anterior ankle impingement surgery, the joint space should be preserved. There should not be an ankle arthritis. Because if you operate on ankle impingement only in presence of osteoarthrosis, that patient may not get relieved of the pain, then that patient may require a later on ankle replacement or an ankle fusion. This is a case of a patient presented with the pain in the ankle for 3 to 4 years, a very young chap. Trauma happened while playing football 4 years before he carried on playing with that. And now we had with the severe pain, reduced dorsiflexion on the affected side. We can see that the movements on the normal side, it has got a good dorsiflexion. And you see the affected side and the above picture video, it has got a very much limited dorsiflexion. And we can see that X-ray, that is a big spur on the talar side. And that is the MRI, which shows that inflammation because of the spur and the impingement. And this is an arthroscopic view where you see there is a big soft tissue and the bony impingement. This is the talus and this is the tibia. When you do the dorsiflexion, we can see that this is a big impingement that does not allow the dorsiflexion to happen completely and present with a lot of pain. So you excise that spur with the help of the scoop, or you can use a burr and make sure that you remove all the impingements from the both tibial side and the talar side. And you can see the down video that the movements has been increased after doing that. In some cases where this case, you can do a loose body removal, like it's the case of 28 years old female presented with the pain and the locking sensation for 6 months duration. And X-ray itself shows that official diagnosis here. And this is an arthroscopic view of that particular patient. And we can see there are multiple loose bodies due to synovial chondromatosis. And here still the joint is preserved. So in this case, if you do a synoviectomy and remove all the loose bodies, can prevent the secondary osteoarthritis in these cases. So you don't need to do a big arthrotomy, just do an ankle arthroscopy and remove all the loose bodies. This is the post-op X-ray. You can see that complete removal of all the loose bodies and synoviectomy. This patient had a complete pain relief. This is another case of 32 years old male patient presented with the pain in the right ankle for 1 year. Again, this patient pain aggravates on walking, even moving ankle, a lot of night pain. So this is a totally a different scenario. So this is not an, you can see this X-ray very carefully. Very rarely you see this kind of lesions in the bone. It's a benign tumor, which you can see almost having a the talar neck and body junction. And this can be relieved by, you can do even the radio ablation, which all of you know that, or you can do a CT navigation. And in this case, we decided to do an arthroscopy because we could remove that all the impingement also, because this patient had a lot of spur. So we had removed the spur, and we can see that is the lesion. We can say that we removed that entire tumor here. And you remove the nidus also. So that has relieved that pain for that particular patient. So we had done 3 cases of these cases. This is a different scenario of 70 years old male patient presented with the right ankle pain for 7 years and pain aggravated while walking and ankle movements. This is a typical ankle osteoarthritis. Of course, you can do an ankle replacement, but we don't have the ankle replacement still in India. So these patients, we decided to do an ankle arthrodesis by arthroscopy. It's a very simple procedure, just with the 2 anteromedial, 1 anteromedial and 1 anterolateral portal. We can see that I'm removing all the cartilage to using the serrated shaver, aggressive shaver, and you can using the image guidance. Just you require 2 screws percutaneously. You can apply 1 on the medial side, 1 on the lateral side. That will, even though the X-ray shows the good space here, but later on, if you see the X-ray, there's a complete healing within the 4 months duration. So the arthroscopic ankle arthrodesis can be done when there is no gross deformity. You can do an arthroscopic assisted ankle arthrodesis. You can see that patient walks so well, and it's very difficult to diagnose, find out which side is operated. You can see that this ankle arthrodesis patient walks normally. Of course, ankle arthrodesis does not allow the posterior displacement of the talus, but by putting the screws posterior replacement of screws from the posteromedial corner can bring the talus back under the tibia in majority of the cases. That can be a clue. When you do a posterior scopy, this is how you position the patient. Same like supine position. If you want to do only posterior scopy, if you need at least you can see this much of 20 centimeter requires for to do the movements. And you do the posterolateral portal, which is a vertical stab incision, and that is corresponds to your first web space. The direction should be direction of the first web space. Indications, you can do a loose bodies, you can do a synovitis, you can use for a posterior OCD or astragonum, or we can do an arthroscopic assisted subtalar arthrodesis or tenosynovitis of FHL in a ballet dancers, or as I already showed, the retroclavicle bursitis. This is the prone position. You mark the lateral malleolus. The tip of the malleolus corresponds to your posterolateral portal. So that is the posterolateral portal, and posteromedial portal again close to the tendoachillus. You mark the tendoachillus, then you go go as close to the possible. Because of the tight space, it's very difficult to get into the triangulation. So use the trocar in the lateral portal, posterolateral portal. Then from the medial side, you can touch the trocar and come in front of the scope to get the more triangulation in the posterior ankle arthroscopy. Here you make the stab incision again, as I told, like ankle arthroscopy. Then you use the mosquito, open it up. Then use the posteromedial incision. Again, it's a blind procedure. Usually I use the mosquito to remove all the fat pad under the tendoachillus so that you can easily visualize the joint space. One of the common diagnoses where you can go ahead with the posterior ankle arthroscopy is the posterior impingement. Make sure that you are ruling out any Achilles or a peroneal tendon pathology that can be confused with the posterior impingement. So usually this is worsened with the plantar flexion, unlike anterior impingement, which worsened with the dorsiflexion. So by repeated push-off or plantar flexion movements can cause pain in the posterior impingement test. As already said that in prone position with the symptomatic knee flex to 90 degrees, passively moves the foot in plantar flexion, look for the pain provocation. If there is a posteromedial tenderness, then could be usually FHL pathology in the FHL tenosynovitis, like in the ballet dancers. In the posterolateral ankle pain, without pain on the medial side, then it could be a problem of trigonal process or a Steedar's process like this. So how to differentiate? The Steedar's process is attached to the talus, as trigonum is completely detached from your posterior talus. So this is one of the cases of prominent trigonum with the pain, and we can see very simple procedure. You go through the posteromedial and posterolateral portal. We may need to compromise the ligament here a little bit to expose the subtalar joint, to expose the trigonum. Because it's already separated here, it's a very simple procedure. We can do it in 20 minutes. What you are seeing is that this is the FHL, that is the lighthouse of your posterior ankle arthroscopy. You should not go medial to the posterior FHL because chances of neurovascular injury is high. So always stay lateral to the FHL to remove trigonum here, or any posterior ankle arthroscopic procedure should be lateral to the FHL. So that is the post removal. After the scopy. This is a case of subtalar arthritis. You can see that there is no gross deformity. It's a case of a rheumatoid patient, severe subtalar arthritis. Again, the posterior talar arthroscopy is gives you the excellent exposure of subtalar joint. You can see always confirm with image intensifier because your ankle joint and subtalar joints are so close. So sometimes you can get confusion in the early part of your arthroscopic career. So if you have a doubt that whether you're an ankle or subtalar, you can use the image. Here I am using again another posterolateral portal to distract. You can see that there is a rod from the anterolateral portal, and I'm working through the both posteromedial and posterolateral portal. I'm using the small burr, removing all the cartilage, but you no need to go beyond the body of the talus, posterior facet, because you have had to take the cartilage only on the weight bearing area. That is more than sufficient. So after removing all the cartilage, then under the image guidance, you use the guide wire like this, and you can see that there's a threaded pin goes inside the posterior facet. Then you use the cannulated screws to fix the subtalar joint. To conclude, ankle arthroscopy is the treatment of choice in osteochondral lesions and impingement syndromes in the anterior side, and numerous new techniques are available in ankle instability. It can be used as a diagnostic and therapeutic in synovitis, and arthroscopic assisted fusions in both ankle and subtalar joints are very, very useful when there is no gross deformity. Of course, learning curve is easy and results are reproducible. Thank you very much for the opportunity.
Thank you so much, sir, for this very interesting presentation and for being with us tonight in this very fruitful session. Thank you so much, sir.
You're welcome, sir.
Dr. Srinivas, please, sir.
Thank you very much, sir, for the comprehensive presentation on ankle arthroscopy and sharing your experiences on such a wide variety of cases. I just have a couple of questions, if that's okay. Regarding the subtalar arthroscopy, do you use a smaller scope or you use the same scope for doing the subtalar arthrodesis?
Yeah, for the posterior subtalar posterior scopy, all posterior scopy, your 4 mm scopy is more than sufficient. You require a small scopy only in the anterior side because anterior side is more tight and smaller space than the posterior because posterior space is more huge. Once you remove all the fat pad, you can easily visualize both the subtalar joint, and also the posterior OCD lesions also can be easily dealt with the posterior ankle arthroscopy. So the 4 mm scope is more than sufficient for posterior ankle and as well as subtalar arthroscopy. But anterior, you should have the small kits because sometimes the OCDs, sometimes when there is a tight joint, very difficult to use the 4 mm shavers, 4 mm instruments, upbiters or a grasper. So you should have a small sets, either 2.7 sets. That is very important that is very handy for the ankle OCD lesions.
Some of these OCDs are difficult to locate, isn't it? How do you manage to locate these ones?
Yeah, because you have already your MRI or a CT scan to know whether lesion is an anterior or a middle or a posterior. If it's only posterior, you're going to posterior. If you're only anterior, you're going to go anterior scopy. But many times you see that lesions could be extending to the middle of the talus. So that is the area is a bit of gray zone, whether you will be confused whether to do an ankle or a posterior. But in my personal experience, I found that anything within the middle of the talus can be easily dealt with from anterior scopy itself by just doing the posterior plantar flexion. I'll ask your fellows to do a plantar flexion that will expose your middle joint completely. So for 1 to 1.5 lesions, it is so easy to do that just ankle arthroscopy. If the lesion is big, more than 1.5 centimeter, where you need to do an ACI or a BMAC, then I do on a medial malleolar osteotomy, I open it up and do the procedure.
And when you do the Haglund deformity excision, how do you know where to stop?
So I always use the image intensifier. I don't, because always it's an eyeballing is very, very difficult. You think that you have done enough job, then you see an image, there will be a second, there will be some Haglund's bump will be there. So always I use the image intraoperatively to make sure that I remove the Haglund's bump. But again, I'm giving a caution to all the youngsters. Your isolated Haglund's deformity with isolated retroperitoneal bursitis is very rare. It's not very common. So most common, they are associated with the tendoachilles spur. So whenever there is a tendoachilles spur inside that is inside the tendon. So it's very difficult to deal with the scopy. I always open up through the posterior midline approach, take down the tendoachilles, remove the whole spur, remove the Haglund's bump, then I reattach it.
Okay. I have a question too about what's called chronic pain in ATFL. It is an injuries. The chronic pain.
Yes, sir.
Called is a minimal instability. You would like to do an scope for these cases?
Yeah, so I think it's very important. It's a very important question. Thank you, sir. So the functional instability and the mechanical instability sometimes is very difficult to differentiate. So patients say that I have a pain, locking, instability. but there cannot be but there may not be a typical mechanical instability. That could be a functional instability. Sometimes in the chronic atrial tear can have a scar and can have an anterolateral impingement. So in those cases, if they don't respond to conservative management, I do scope. I just do a debridement. I don't do a repair or reconstruction because these patients may not have a mechanical instability. So I do just a decompression and remove all the soft tissues, make sure that ankle is moving freely and leave it.
Just shaving for the
Yeah, only if there is a scar with the anterolateral impingement, I just do a decompression. If the same patient has got a mechanical instability, then I do a repair or reconstruction.
okay.
Which I showed in the video. Most cases I do a all inside arthroscopic repair if there is a tissue quality is good. But always I counsel the patient, if I do an arthroscopy, but if your ATFL tissue is very bad, then I may add an internal brace, or the tissue is very bad, I may do an open reconstruction.
But you know, of course, you know that the era of coming now about minimal instability, and you have to sometimes, if we can repair to this instability, I think it prevents the pain, and the chronic pain is completely relieved.
Yes, sir.
But actually, I'm agree about if it is functionally okay, we can do it. Thank you very much.
Thank you, sir.
Thank you.
In association with OCD lesions, if there is associated delamination of the articular cartilage, how do you manage that? Minor delamination or major delamination of the articular cartilage from the underlying subchondral bone if the cartilage comes off.
So it's all the OCDs you have articular cartilage comes off. The problem is to how to do. I mean,
not just around the OCD, sir. Around, not just on the OCD, but around the area.
Yeah. So when there is a very superficial lamination, you can superficially debride and leave it. But if you have if you think that it is going to, in extensive cases, sometimes MRI may not give you the diagnosis. Sometimes when you go inside, if you put a probe, then if you take off that entire cartilage, that may come off. You can lift it off very easily. That is very rare in some, because most of them MRI can diagnose. But in that cases, that prognosis is going to be very bad, because if you leave it also, that pain is going to have. So you can remove it. You can do all this procedure. They can have a temporary pain relief in short term, but long term, I counsel the patient, they are going to have an arthritic changes in the future.
Thank you very much, sir. I think there is one question here. Deltoid ligament tear can be repaired by ankle arthroscopy?
No, I have not done. I have done a open procedure because I don't usually we do with more cases. You have done with a lot of the ankle fractures, but isolated deltoid injury also I had operated. But what I get is very, very few. I don't know why, but I had done only 2 cases in the last 3 years. I had done an open procedure. I do open repair, not arthroscopically.
Is there a role for arthroscopy in ankle fracture fixations?
Of course, it's many, because I didn't discuss much about it because you know me, and I was doing all the trauma. Now I don't do a foot and ankle trauma. Also, I do all the elective procedures of foot and ankle and all the arthroscopy of shoulder, ankle, hip, and everything. But foot and ankle, I do only elective procedure like professor. I do a lot of Charcot also, but I don't do in trauma. But in trauma, it definitely is a very important tool to assess your syndesmosis, because that is the one controversial area where people get confused. And if you are having scope that is in handy, always use the scope to diagnose, assess your reduction of your syndesmosis.
Thank you.
I have a question.
Actually, sir.
Yes, sir.
Actually, I have
Professor Hani.
Okay. Actually, I have an experience about ankle fracture, especially in bone fracture. I think we published a paper in 2015 about the assessment of arthroscopy and treatment of as assessment. So it is very useful to make an debridement, and also tissue, all tissues or debride everything. And also we can sew the articular surface, which is very, very useful in management. So I think, but nowadays the ankle arthroscopy is now going to assess the fracture, especially in ankle. If you don't like to open the ankle joint, I think it's very good.
Yeah, absolutely agree, sir, because it is very helpful tool. I mean, apart from syndesmosis, of course, as Professor said, you can address all the cartilage lesions.
Yes. Professor Hani, this was the question I want to ask about it. The use of assisted arthroscopy assisted management of pilon fractures and how to assess the articular surface. Professor Hani has just asked. Thank you so much, sir. We have another question, Dr. Sarnivas.
Yeah, from Dr. Al Sultan Muhammad. Please, Professor, when you remove big OSD, you put bone graft, and when directly or after some time. So I think it's OCD probably.
Yeah, I think it's a OCD question.
Yes.
Yeah, so sometimes when you have a lesion over the dome of the talus, where you cannot do a very difficult situation sometimes. And the lesions are very small, like maybe around 2 centimeter, or maybe 1 to 1.5 centimeter with bone loss. You can do an Wurtz procedure. We can take a plug from the knee joint and we can put it there. I have done a very few cases on that. But if you have a big lesions, then you have to do a bone grafting. I do a biopsy at the same stage. I do a bone grafting and I take a biopsy from the knee and send for a ACI. I do a ACI. So once it comes back after 4 weeks time, then you apply the ACI over the defect.
I think that's all. We don't have any more questions.
Okay.
Thank you very much for the excellent lecture and the discussion.
Thank you everyone for the opportunity, and good to see all the Egyptians friends. Thank you very much.
Thank you so much, sir. Finally, I would like to thank all our dear colleagues and our dear professors, Professor Sandarajan from India, Professor Hani Elmowafi, the president of the Egyptian Orthopedic Association, Professor Sarnivas, my dear friend and the moderator from the Indian side, and all our attendees. Thank you so much and see you next Friday. Thank you so much. Have a nice time. Thank you so much, sir.
Thank you.